Thank you. This was supposed to be from Cynthia Lemire, who couldn't make it today. Just some disclosures. The antibody that we tested was provided by Probe Biodrug, and I'd like to thank the Focus Ultrasound Foundation for supporting this work. So what we were looking at is pyroglutamate 3 A-beta, which is a pathological and toxic form of amyloid that is present in many plaques and in vascular amyloid. Probe Biodrug has a murine anti-pyroglutamate antibody that we were looking to see if we could improve by delivery with Focus Ultrasound. And we looked at these in old mice, APP PS1 mice, 16 months old. We used a system that had an 835 kilohertz transducer. We use Optison microbubbles at about 2 times the dose that we normally use, and we targeted 2 locations in each hemisphere, as you can see on the fluorescent image on the right, which is from a pilot study. We did 3 weekly treatments with 1 week apart, and then a week later we did behavioral testing, followed by euthanasia and a battery of pathology tests. We had 6 groups, 4 transgenic groups, no treatment, FUS only, antibody only, and FUS plus antibody. And then we also did wild type controls and animals that just received FUS. So jumping to some of the results, there's a lot of results here. I'll try to show the relevant ones. So first in the behavior, the water T-maze, we showed the strongest improvement when we had antibody combined with Focus Ultrasound. We did see some improvement with the antibody alone. And on day 8, the combination showed a significant improvement in learning, where we didn't see a significant improvement with the other groups. Looking at the plaques, we did see a reduction in A-beta 42 in the hippocampus, but not in the non-targeted prefrontal cortex. And again, the only significant improvement we saw was with the combined group of antibody and Focus Ultrasound. We didn't see any change in A-beta 40. Looking at the pyroglutamate 3 antibody, A-beta, in the hippocampus, again, we saw a reduction both with the antibody and with FUS, but the significant improvement was only with the combined treatment. And again, this was a local effect. We didn't see it in the prefrontal cortex. We also saw an increase in the hippocampus in the number of synapses in the combined group compared to the antibody-only group. We saw more synaptic puncta in the hippocampus than those with antibody alone. And we also looked at synaptic markers. We saw more of these in the wild-type mice, as you would expect, than the transgenic mice, and we didn't see any effects from FUS alone. We saw the combination therapy increased all of the synaptic markers in the Alzheimer's model mice. With the antibody alone, we only saw in select markers. We looked at IBA1 staining for microglia or macrophages and monocytes, and we saw an increase both with the antibody and with the FUS plus antibody. There was no significant difference between those two. And we also saw, we did not see an increase with FUS alone. We also looked at the intensity of the microglia staining. We saw, again, an increase with antibody and antibody plus ultrasound. And then in CD68, we saw an increase with the antibody, but not with the combined group. We also looked at LY6G intensity, which is a marker for microglial homeostasis. And this was an interesting result. We saw only in the combined group a very large increase in this staining. And we did not see that with the antibody alone or with the other groups. And finally, we did not see any increase in microhemorrhage, any significant increase from FUS compared to the antibody plus FUS or FUS alone. So to summarize, with the combined treatment, we saw increased learning in the water T-maze test, significantly lowered AB42 and pyroglutamate 3 A-beta. We saw an increase in synaptic markers in the hippocampus. We did see an increase, as others have, with IBA1 positive microglia with antibody and with FUS plus antibody. And we saw LY6G plus monocyte granulocyte neutrophil infiltration, and these were associated with the plaques. We didn't see any increase in GFAP immunoreactivity or neuronal counts, and we didn't see any difference in microhemorrhage between the groups. So this appears to be a useful tool for us to enhance the efficacy of this anti-A-beta immunotherapy. We see this even in the really old mice in this model. And the presence of, we saw a presence of peripheral immune cells, which is interesting. This is something that we need to look into. And this looks like something that we can do and repeat when combining ultrasound with this type of antibody therapy. Thank you.
Sure. You're first.
Thank you very much for your talk, Nathan. I'm just wondering, did you guys use a fixed pressure sonication, or did you use any cavitation feedback to achieve blood-brain barrier opening in this study?
No, we used a fixed pressure. It was at 327 kilopascals. We did have cavitation monitoring that would decrease the power if we had inertial cavitation, but we didn't use the active controller.
I have a question regarding the mechanism. Considering that pyroglutamate A-beta only constitutes a very small fraction of A-beta, how do you think the system gets activated? And it's absolutely fascinating that you also get a reduction in A-beta 42 or in total plaque load.
I think that's a question that's over my head, and I think I would need to talk to somebody from the...
Okay, no, certainly.
Sorry.
But are there further questions in the audience to Nathan Mcdannold? If not, thanks again.
Thank you.